you have today's guest speaker who would actually highlight the recent advances. Next slide. When we look at of patients with breast cancer, this is all breast cancers, advanced as well as early. This is one of the number one cancers we are diagnosing. To the lung cancer, that's what we see here. And with our numbers, with this Globocan data, to 626,000 women getting diagnosed with dying due to this disease. Next slide. If you just do the maths and just looking at these incidences, and if you just do the total population, you know that the Globocan data actually selects data of the cancer registries of India. But just by doing the maths, I think you can see that almost more than 11 to 12 lakhs of women will get this disease, and about 7 to 8 lakhs of women would lose their life due to this disease. Next slide. Now, we all see these patients very commonly, and we often talk about that history data and also from the publications from major institutes in the country. And the reason for this shape of our population pyramid. If you see that we have a lot of people who 30 to 60, and therefore just by the sheer number of so many people in that age group, we do have a lot of cancer the younger population as compared to older population. Next. Because many of our patients are young. Next. Because many of our patients are younger population, and you do have 30%, and the HER2 positive again is about 20%, and the remaining.
Sorry, your voice is not clear, Dr. Ashish. Your voice is not clear.
Dr. Ashish, your network is small, I guess.
I think, yeah, the voice is cracking.
Is it okay now? Can everybody else unmute? I also see. Can everybody else mute? Because I also hear a lot of noise.
Sir, can you hear us clearly?
Yes, I can. Yes, I can.
So, but I think we are losing you in between very often. Vidit, can you make Dr. Ashish co-host again? I think he's joining.
Yeah. Piyush, make Dr. Ashish co-host.
Yes. Dr. Ashish.
You hear me now? Hear me now?
Yes, sir.
Yes. So, is it better than before?
Yes, sir.
Yes, it's better, doctor. Yes.
So what I was saying is that because we have a lot of patients in the younger age group, we do have, but still our ER positive is close to about 50%. Next. And this is consistent. The country, it's if you look at all across India, it's about the majority of our patients are going to be like in the age group of 40 to 60. Next. And people have looked at outcomes in these as per their age, and this is a study from Hyderabad which they found that patients who are younger, that is less than 40, their survival is about 10% lesser 5-year survival as compared to people in the older age group. Next. This is another report from Delhi, Same epidemiology, the distribution, if you see, again, about 20% of our patients would present with metastatic cancer, and it's about 70 to 80% of them at the time of diagnosis. Even in the earlier cancer, most of them actually present with stage 3 disease. Next. And we're looking at have early disease or advanced disease. Next. And this is again some data from Delhi. Here again, this is outcome on metastatic cancers. Even in metastatic cancer, hormone receptor positive comprises about 40 to 50%. And most often, these patients are treated first line with tamoxifen, and about 30 to 40% of them would get an aromatase inhibitor. Next. And if you look at the outcomes, again, your overall survival as expected, the hormone receptor positive HER2 negative group has the better survival. But if you look at the median progression-free survival or overall survival here, this is not what we see in the landmark phase 3 trials. Here it's close to about 2 years, which is much less than what is expected. Next. And if you go by the guidelines, we know endocrine therapy, as Dr. Subramanian pointed out, is what has to be tried initially. Next. And based on this, various guidelines have recommended that you must try at least 2 or 3 lines before you move on to chemotherapy. Recently, we have seen in the last 5 years, even in India, we have availability of targeted agents, especially the CDK4/6 inhibitor. Next. Everolimus has been around, and these agents have moved into guidelines, and most guidelines recommend their usage in first line, and also if not in first line, definitely in second line. Next. And if you look, the recommendations are because they, on an average, a CDK4/6 inhibitor use would improve your progression-free survival to about 10 to 14 months. This is an additional of 10 to 14 months over and above your standard endocrine therapy. Next. And this is what has changed practice. This is a pooled meta-analysis, Lancet Oncology 2020, which has looked at all the CDK4/6 inhibitor. And if you see consistently, it has improved your PFS by about 10 to 12 months. Even here, what you can actually differentiate patients based on whether they are younger patients, whether their disease-free interval to their adjuvant therapy was less than 1 year, whether they have de novo bone-only metastasis or multiple visceral metastasis. And patients who are younger, patients who have visceral metastasis, who relapse quickly on adjuvant endocrine therapy, they have lesser survival and they derive lesser degree of benefit as compared to your treatment-naive older women. Next. So our guidelines are being updated with all this information. This is the recent ABC5 guidelines. What I want to highlight is these agents not only improve survival. If you look at the ribociclib recommendation, it's now in first line premenopausal women, the MCBS score, that is the mean clinical benefit score, is about 5. That means there is an improvement in even quality of life with addition of CDK4/6 inhibitor in first line. Next. And because of this, there has been a rapid uptake of these agents in first line. This is population level registry data. It's called the Flatiron data from the US. And you see over the years, the uptake of CDK4/6 inhibitor in first line has gone up to as high as about 50%. Next. But is this true in India? In India, what is the usage of CDK4/6 inhibitors? We really don't have good level data, but whatever we have is this is a poster again from Bangalore. They have looked at 133 patients and how they have used these agents. Next. This is not more about the access, but it's more about how our patients are deriving what kind of benefit. What you see here is a response rate of 71% and a PFS of about 18 months, which is as expected to the published literature. Next. We also have data from down south from our own Cancer Institute Adyar, where our patients have shown an impressive PFS of 18 months with the use of palbociclib. Next. About other endocrine agent targeted therapies. Now, everolimus, we all have been using it. We know it's a difficult to use drug.
And with our limited experiences, it has not made a major dent in our treatment outcomes. Next. So that I'll conclude. I mean, just to set the stage, usage and access to these targeted agents are still limited. Our outcomes are comparable to Western data if we can lay our hands on these drugs. Even though we have younger patient population, but their survival may be lower because of disease characteristics and not because they behave differently from the Western world. And cost remains an important issue. With that, I'll conclude and hand it over.
Thank you, Dr. Rasil Singh, for the excellent overview of the Indian scenario. We go to the second topic, the main one. It's going to be by Dr. Dejan Sturik. He is the Director, Termier Center for Targeted Therapies and Investigational Cancer Therapeutic Program, Mass General, Boston. His background is many abstracts, research articles, and many leading journals. He has extensive experience with PIK3CA mutation inhibitors, having 300 plus patients in clinical trials. He is the lead principal investigator for the SOLAR study and is a PI for Miley trial. His key research interests are genetic alterations associated with therapy resistance, advancing the development of new agents against PIK3 mutations, and providing insight into new treatment strategies. He is going to give us his talk on picking the right strategy for the treatment for PIK3CA mutated HR positive HER2 negative advanced breast cancer. Dr. Dejan Sturik.
Thank you so much for a kind introduction. It's really an honor to be here today and share some of my experience with you. I've been involved in development of PI3 alpha inhibitors since 2009, and I ran that first in human trial of both Alpelisib and Alpelisib, and actually some additional PI3 alpha inhibitors. And over the years, I treated about 300 patients with these agents, and hopefully some of the experience that I gained throughout those years, I'll be able to share with you and also hear from you feedback and your thoughts about this particular field. So let me share my slides. So hopefully you can see them well. We'll discuss the treatment strategy for PIK3CA mutated HR positive HER2 negative advanced breast cancer. These are my disclosures. I receive consulting fees as well as research funding from these companies. I'm a practicing breast oncologist. Majority of my practice is metastatic breast cancer patients. And I would like to share my experience with one of those patients that illustrates some of the key questions in this particular area of breast cancer oncology that will be discussed throughout this presentation, and some sort of foundational data for these decisions that with this particular case will be provided in those subsequent slides. So let's start with this particular patient, who was a 52-year-old premenopausal woman with a history of rheumatoid arthritis, as well as invasive ductal carcinoma of the left breast, that was treated with lumpectomy and sentinel lymph node biopsy for what was ultimately deemed to be a T2N0 tumor. It was ER positive, PR positive, HER2 negative. Oncotype was 23. She subsequently received radiation therapy and was placed on adjuvant tamoxifen, which for whatever reason she struggled quite a bit, some challenges keeping her on that adjuvant hormonal therapy. And 3 years into it, she developed a new progressive right shoulder pain, which initially she thought was flare of rheumatoid arthritis, but ultimately ended up being a recurrent breast cancer with imaging showing diffuse bone and liver metastasis. As it's standard at our institution, all patients with suspicion for recurrent breast cancer undergo biopsy regardless of the site of disease, unless there are some exceptions, primarily to perform repeat receptor profiling, and she was still ER positive, PR positive, HER2 negative, and also in our institution, it's pretty much a reflex test to send mutation profiling to determine not just PIK3CA mutation status, but some other oncogenes are tested with this test as well. Based on the really a lot of data about the role of CDK4/6 inhibitors in the frontline setting, my decision was not based on the mutation profile that we send out. Necessarily, I already knew that the CDK4/6 inhibitors will be used in the frontline setting, but a test done at that time point, in my mind, provides some additional data so you can plan more than one line of therapy, and you can, based on the results, also perhaps select the endocrine agents a little bit better. So this lady got an aromatase inhibitor, latrozole with ribociclib, and actually ended up being on this treatment for 11 months. So this was much less than we would expect. Probably there's several reasons for this, but she did get 11 months on that frontline therapy. At that point, recognizing temporal evolution of ER-positive breast cancer, which is quite remarkable. These tumors are changing over time quite significantly. We decided to perform repeat mutation profiling. We at that point knew from her initial tissue profiling that she had a PIK3CA mutation, and the real one, the hotspot mutation, the kinase domain of the enzyme, the H1047R mutation. But the repeat ctDNA profiling, it is our practice usually for follow-up mutation profiling studies to primarily use ctDNA assays. She was also found to have a new acquired mutation in ESR1, the D538G. This mutation results in ligand independence of the estrogen receptor and activation of the ER signaling. It's not surprising since the patient received frontline AI-based therapy. Based on presence of both ESR1 as well as PIK3CA mutation, we decided to treat her with fulvestrant and alpelisib. At that point, she had considerable bone pain from stemming from her bone metastases, as well as some, although not high, burden of disease in the liver. Relatively quickly, within weeks of starting alpelisib-containing regimens, she reported remarkable improvement in her bone pain and reported that she's feeling really well. She did have one side effect that I want to stress out in these initial slides of this presentation, the on-target side effect of alpelisib that stems from the interference of the drug with insulin signaling, which is hyperglycemia. This patient had as her baseline parameters somewhat borderline sort of metabolic status with fasting plasma glucose of 100, A1C was in pre-diabetic range of 5.8, and her BMI was borderline at 26. Very quickly, and actually the first follow-up after starting alpelisib, this patient had a rise in glucose going from 100 at baseline to close to 200, just at the cusp, 200 at the first assessment, essentially when she came back from her day 15 fulvestrant. After starting metformin, as well as some dietary recommendations, and without those modification, we managed to sort of keep that glucose at either normal or grade 1 level for the rest of her treatment. So a few of these slides, we can talk some of these decisions for quite some time, and I'll try to provide some sort of background information as well as far as preclinical understanding of this oncogene is concerned, as well as clinical data that supported some of these decisions during the care of this patient. So this is the summary of the data we have with CDK4/6 inhibitors, which support the decision to use them in a first-line setting. This was already mentioned in the previous presentation, what is remarkable to me to see that these studies so uniformly across various programs have produced pretty similar hazard ratios with remarkable median PFSs on the experimental arms, particularly for Western ribociclib in the first line setting. When you look at that particular cohort, you're getting 33.6 months, which is, I mean, to me, this is incredible. When I was a fellow, my mentor, Eric Weiner, would show overall survival of metastatic breast cancer patients being 22 months. To see that in one subtype of that breast cancer, we can get 33.6 months PFS on just one line of therapy is testament to the remarkable progress that the field has made over the last few years. Now, when we do make that decision to start with a CDK4/6 inhibitors, we are setting the stage for these tumors ultimately progressing on that therapy and developing resistance, which can then impact the subsequent treatment decisions. What do we know about resistance to CDK4/6 inhibitors? And generally, as it was really nicely reviewed in this now 2-year-old paper, we think about resistance to CDK4/6 inhibitors in sort of two big groups. On one hand, you have cell cycle non-specific mechanisms, things that alter signaling pathways outside the cell cycle machinery itself. And then you have changes in the cell cycle machinery, okay, deeper in the cell. So among those cell cycle non-specific mechanisms, I would like to select three. The very first clinical resistant mechanism described in the field at Memorial Sloan Kettering by Sarat Chandralpati was loss of ER. So I think we should remember that a small subset of these patients, as they progress on CDK4/6 inhibitors, can completely lose ER. More commonly, though, you have changes either at the receptor level with FGFR amplifications or changes in the signaling components within the PI3 kinase pathway, including changes in PI3 kinase itself, AKT, or mTOR signaling. There are some others, but I think I would like to point out this interesting observation that PI3 kinase pathways itself gets hyperactivated as these tumors progress on CDK4/6 inhibition. In terms of cell cycle dependent or specific mechanisms, there you would expect a very common mechanism of resistance would be loss of RB. Luckily, we don't really see that often. The tumors that lose RB are really nasty. In common oncological practice, small cell lung cancer is a RB null disease, and usually RB null breast cancers do not really behave particularly nicely. Luckily, that's pretty rare alterations, and there is a smattering of additional changes such as amplification CDK4, CDK6, cyclin E that we see quite often as well. Now, knowing that these tumors evolve and alter some of these pathways, interesting to see what's the place of Alpelisib as a PI3 kinase inhibitor in a post-CDK4 setting, and we'll talk about this in the rest of the study. One thing that I would like to point out from the very, very beginning, that these targets are not static. They are not just there kind of on its own. They are interconnected in a tight mesh of signaling molecules. In a sort of simplified version, I like to show this triangle that emphasizes the three most important nodes in this signaling network. On one hand, you have estrogen receptor. On the other hand, you have CDK4/6. And up there, you have PI3 kinase pathway. Whatever you do to the ER-positive breast cancer, with one of the angles, one of the signaling nodes in this triangle, the other two get activated. So if you try to block ER, PI3 kinase CDK4 go up. If you try to block ER and CDK, the tumor escapes through PI3K. If you try to block PI3K on its own, ER signaling goes up. So this is why we almost never, ever give PI3 kinase inhibitors as single agents, because you have this adaptive increase in the other component of this triangle. And this triangle also shows the new age of clinical trials. Now, after developing various doublets, whether it's hormonal therapy plus CDK or hormonal therapy plus PI3K or mTOR. Now, the new wave of clinical trials are focused on developing regimens that at the same time target all three angles. There are now a series of these trials, and we'll see whether we'll be able with these triplets to come up with even better outcomes than we can with doublets, similar to what we've done with HER2, where a 3-drug combination in the Cleopatra trial have produced truly remarkable results in the HER2 disease. Now, we have a considerable amount of correlative data from various CDK4/6 studies, and I would like to single this one out that looked at fulvestrant palbociclib combination, and I would like to show the number one resistant mechanism that emerges with these patients. It's not something that we necessarily expected. We expected that RB changes will be number one, but in line with that triangle that I showed you, the tumor is always trying to do something with one angle of that triangle. In this particular trial, majority of sort of the number one resistance mechanism that we observed was actually mutation in the ESR1 as well, particularly this one called Y537S that really got kind of enriched in the post-treatment samples, showing how these ER positive tumors are always trying to kind of use old tricks, basically. They're trying to activate the very pathway that's important to these tumors. And I think a big part of the new wave of drug development in this field will be to find even better estrogen receptor targeted agents than we currently have. Now, knowing that we start with an AI, a CDK4/6 regimen, now we have a decision to make in terms of what to use in the second line setting. And there are a lot of things that go in our head. In some instances, it may make sense to change the endocrine agent, but keep the CDK, okay? This is considered investigational, but some patients, some people in the clinic do use that, particularly if the patient is just the ESR1 mutant, and they hope that with the change of the endocrine backbone, they can get more mileage from CDK, although this is not considered standard of care. Another approach is to keep the endocrine backbone, but change the targeted therapy, okay? This is also not considered standard of care, although it is used in some instances, such as if your frontline treatment is fulvestrant. In my practice, I rarely will go back to an AI after fulvestrant, and there I will change the targeted agent. The standard of care approach is the third one, where you change both the endocrine therapy backbone and you go from a CDK4/6 inhibitor to either PI3 kinase inhibitor for mutant patients or an mTOR inhibitor for wild type patients. And now the whole slew of clinical trials are being done using this fourth and fifth paradigm, where you're either doing an add-on third agent, or you start with 3 agents from the very, very beginning to shut down all 3 angles of that triangle. And we're hoping to see results of that, and we're waiting for them with great excitement. But right now we're here, and this is what I've done with my patient in this first scenario that I described. Going from letrozole ribo, we went to fulvestrant alpelisib. Now, what is the data that this decision is based on? Those clinical data come from the pivotal study of alpelisib, the SOLAR-1 trial, which was a very interesting study. This study answered 2 questions, not one. It didn't just answer whether alpelisib added to fulvestrant is better than placebo added to fulvestrant. It answered also the question whether PIK3CA mutation is a predictive biomarker. In other words, is it that it will be in the PIK3CA mutant cohort that we will see the benefit, not necessarily in the PIK3CA non-mutant cohort. The primary endpoint of the study was prolongation of PFS in this PIK3CA mutant cohort, but we were able to analyze both cohorts, and the result that was seen is that the benefit was coming primarily from the PIK3CA mutant cohort. And this is what we observed. The alpelisib plus fulvestrant combination produced a PFS of 11 months, which is almost double than what was observed in placebo fulvestrant arm, which was 5.7 months, with hazard ratio being 0.65 and a significant p-value. Okay, so this observation is both clinically and statistically significant based on these parameters. When we look at various subgroups, we see consistent benefit whether the patient had lung or liver metastases, whether they had prior chemotherapy, whether they were treated in the first or a second line. And the two subgroups that are really interesting and have shed some light on sort of how these drugs should be positioned. On one hand, we did have a small number of patients with prior CDK4/6 treatment. When the trial started, the pattern of use of CDK4/6 inhibitors was such that only 6% of patients ended up being with prior CDK4/6 treatment, but the hazard ratio in that side, we didn't see any surprises, although additional trials, including BELIEVE trial, was designed to gather even more data in this post-CDK4 setting. As far as the endocrine resistance is concerned, with initial iteration of the study, we allowed endocrine-sensitive tumors. In other words, patients who progressed more than 1 year after completing adjuvant therapy, okay? And in those tumors, hazard ratio was really close to 1, which actually made quite a bit of sense to us. We felt that PIK3CA mutation plays a role in endocrine resistance, and in subsequent amendment of the study, we focused only on resistant tumors, whether they are primary resistant tumors or secondary resistant tumors, and sensitive disease was excluded. Now, looking back at the two big cohorts of patients, the first-line patients and the second-line patients, something interesting can be seen. If you carefully look, the median PFS in both first-line and second-line patients is almost identical, 11 months. But what happens as you progress from first to second line, your control arm, the fulvestrant arm, is performing very, very poorly. It's going from 6.8 months to 3.7 months. And your hazard ratio actually improves from 0.71 to 0.61. And that makes sense. Remember, PIK3CA mutation is a truncal mutation. It's present very, very early in the disease, even as early as DCIS. So it's not the presence of the mutation that matters so much. The mutation is, we call it permissive oncogene. It doesn't get activated on its own just by mutation itself, okay? Something else in the milieu of the tumor, in the signaling pathways upstream of PIK3CA also have to get activated and now push the signaling through that wide open PIK3CA node, and that's when you see the pathway to go up. And not surprisingly, as you go from first line to second line, those changes occur even more frequently and the pathway gets activated more and more. And here is, I want to stress how important it is. The mutation it's not equal to activation. Mutation is just one component of activation, and additional changes happen as the tumor evolves, and it's in that second line setting where you have a perfect storm. That's when the pathway is fully activated, and that's where alpelisib really does add quite a bit. You're going from 3.7 months to 10.9 months in this particular setting. When you look at tumor shrinkage, it's nice to see that close to 76% of patients on alpelisib fulvestrant have some degree of tumor shrinkage, and objective response rate doubles. You have 36% objective response rates in patients with measurable disease compared to 16.2 in patients on the control arm. Okay. Now, I already told you that there is a relatively small number of CDK4/6 pretreated patients, and for this reason, a completely new study was designed, which consists initially of two arms, and then we added a third arm. So we study in this trial alpelisib fulvestrant given to patients who had prior AI plus CDK, or we give AI plus alpelisib to patients who had prior fulvestrant. So we are switching both drugs. And then in third arm, we actually we allow fulvestrant to be given after prior treatment with either chemotherapy or fulvestrant. So this third arm will be particularly interesting because it's going to allow us to even look at patients who got fulvestrant, post-fulvestrant as a partner to alpelisib. Hope Rugo presented very recently at ASCO results from the arm A, and this study based on the pre-specified criteria, met its primary endpoint with more than 50% patients being alive without disease progression at 6 months. And PFS in this group of patients was 7.3 months. Remember, in SOLAR-1, where we have combination of first and second line patients, we got 11 months. So I think, it may be challenging to directly compare this number, but there is possibility, since the number is slightly lower, that there is some cross resistance between CDK4 and PI3 alpha inhibitors. So we spent a considerable amount of time and published actually recently a paper in Cancer Discovery showing what potentially that resistant mechanism could be in a small subset of patients, but largely, even in a post-CDK4 setting, alpelisib does produce considerable clinical benefit. Here we see a tumor shrinkage in BELIEVE trial compared to SOLAR. You see again, there is considerable amount of patients where you have disease shrinkage, although there are maybe slightly more patients where you do not see necessarily them being sensitive to alpelisib fulvestrant. So studying these patients in more detail, the genomic level, hopefully will shed more light in how that we can then use to even better sequence these treatments. Here, I want to show you a third study. So SOLAR-1 is the pivotal trial. The BELIEVE provides evidence about patients in a post-CDK4 setting, additional evidence. And this trial, the first human trial of alpelisib, so-called X2101, gives you some data on activity of fulvestrant alpelisib in patients who had prior fulvestrant. And in this particular trial, we had heavily pretreated patients with median of 5 lines of therapy. And there, as you can see, about half of them got fulvestrant before getting fulvestrant alpelisib. And despite that, some of the deepest responses were seen in patients who had prior fulvestrant, suggesting that it's not necessary always to switch that hormonal backbone. All the additional trials are needed to really clarify that further. In that particular trial, the PFS, remarkably, this is a patient with 5 prior lines of therapy, was 9.1 months in PIK3CA mutant patients. So together, these 3 trials sort of complete the picture and try to answer. Obviously, the data from the pivotal trial demonstrate the utility of alpelisib. BELIEVE provides additional data in CDK4 setting, and X2101 gives you some data in heavily pretreated patient, and also provides some of the limited data on use of fulvestrant post-fulvestrant, which is a big problem in some countries. But in my practice, if I use fulvestrant in upfront setting, I will rarely go back to AI because of high prevalence of ESR1 mutation in pretreated patients. And in my practice, I sort of follow a similar sort of paradigm that we use with HER2, where Herceptin is just, we keep using Herceptin despite changing the chemotherapy backbone, because you're trying to use the best agent against particular target that you have at the moment. Hopefully additional targeted therapy agents against ER will be available soon, and we'll be able to then even better target the ER component of that signaling network. Now, why is alpelisib, and I alluded this in the beginning of the study, why is alpelisib not given alone? When we initially designed the trial, we designed that first human trial as a basket study. We thought that we're going to give alpelisib to the PIK3CA mutant tumors and we'll see universal response, as it was seen with ALK or EGFR or some other targets. But what we observed with PI3 kinase inhibitors is disease-specific and context-dependent resistant mechanism. Breast cancer has unique feature that when you give a PI3 kinase inhibitor alone, estrogen receptor goes up, okay? You see increase in RNA levels, protein level, FES-PET, downstream proteins that are regulated by ER, particularly progesterone receptor or GRB1, everything goes up. So it's like you try to block PI3K and ER, the tumor is fighting back by activating ER. It's not estrogen that's changing, it's the ER that's going up. And to me, it makes a lot of sense that we need to try to degrade the ER receptor to prevent this feedback activation. And it's not a sort of random that the very first combination we studied in the phase 3 trial was actually fulvestrant based combination as opposed to AI based combination. Okay, so I think this also illustrates how tumors are not sort of static. You need to look at them when you give the drug. You need to see what happens. It's like checking the engine as it's running. You can hear or observe things that you cannot if you just do a snapshot before treatment. And those beautiful work done by Anna Bosch was now published 5 years ago in Science Translational Medicine. That actually is one of the foundational observations for the use of PI3K inhibitors. Now, how do we give alpelisib? Alpelisib formulated in sort of 3 different packs. In the starting one, we use 250 milligram tablets. And then if you need those reductions, you're giving 250, but you're giving them as a 200 plus 50 or just 200. And I have to warn you that if you try to dose reduce, it's not that straightforward because you don't have the right pills to go from 300 to 250 on the fly. You have to exchange and get new supply because you need 250 tablet. It would be nice if there was some sort of more kind of friendly pill sizes, like for example the way the ribociclib is packaged, but this is what it is, and we have to just be aware that if you need to dose reduction, you have to prepare to provide a new scripts. It's given together with fulvestrant, administered in a standard way. And I would point out that this day 15 dose, it's really nice because that loading dose requires that the patient comes mid-cycle. And this is on that day 15 where you as a physician have opportunity to recognize early the side effects of this drug, hyperglycemia, and reinforce the need to prophylax for rash or help the patient with rash. So that day 15 visit, I consider is the most important visit on patients treated with alpelisib. In other patients, you may not even see that patient. They come, they see the nurse, they get the injection, and you see them on the day 1 of the cycle. But on alpelisib, I always see this patient myself because at that time point, a lot of side effects can occur, and this is the opportunity to intervene. What are the side effects we care about? There are 3 main side effects that I want to discuss. One is the gastrointestinal issues. And compared to earlier generation PI3 kinase inhibitors that cause colitis, this is extremely rare with alpelisib. Alpelisib causes diarrhea that's relatively easy to manage. It's usually lower grade, and sometimes not even caused by alpelisib. It's caused by metformin that's given to patients for management of hyperglycemia. Okay, the 2 side effects that do matter a lot is hyperglycemia and rash. So hyperglycemia typically will happen by that day 15. You'll see some changes in glucose, and it's really important that we are all very, very sensitized even to low-grade hyperglycemia. I always intervene, even if I see mild change in glucose. Why? Because this is the on-target side effect of this drug. It will get worse, typically, unless you do something, either with dietary recommendations, starting metformin, paying attention if you need to dose reduce, okay? The 3rd side effect, rash, is very important, but we can prevent it. And we'll talk in subsequent slides that with a simple intervention, starting an antihistamine such as cetirizine, a non-sedating antihistamine, we can dramatically reduce incidence of rash. And that's the first drug that I prescribe together, give patients together with alpelisib. Now, managing this, on one hand, therapeutic effect that can be quite considerable, and some of these side effects, particularly hyperglycemia, this is why we are oncologists. This is the essence of being oncologist, and we have to constantly look at both sides of this curve, okay? Now, how narrow or how wide this is can determine the destiny of these drugs. So these 4 groups of drugs are all called PI3 kinase inhibitors, okay? The first 4 were so-called dual inhibitors that block PI3K and mTOR, failed. Then pan PI3 kinase inhibitors, they went after the PIK3CA alpha, but they also went after 3 other isoforms of PI3K. Very similar, but distinct roles and distinct functions in the cell, the beta, gamma, and delta, failed. Then Alpelisib was brought in, which hit just 3 of them, trying to dial out beta to make the drug more tolerable, but it wasn't enough. The drug was causing colitis, okay? And finally, Alpelisib, as an alpha selective inhibitor is the one that actually made it all the way through and gets approved. I have to warn you, and you guys are all very experienced oncologists, that all of these drugs are called PI3K inhibitors. Nominally, they are the same class, but you see how different they are. 3 of groups failed and only 1 succeeded. We now have a similar problem with this class label with CDK4/6 inhibitors. They're all 3 of them are CDK4/6 inhibitors, but they're different drugs, different structure, different PK properties, different side effects. Not surprisingly, we're starting to see, although we have similar PFS, we have different OS data with the 3 of them. We have different adjuvant data. So we cannot just, it's a class, we can exchange drugs freely. We have to really look at the features of every drug and look at every trial very carefully as we make decisions for our patients, because at any given time, we can give only 1 drug. We cannot give all 3 to them. So we have to make these decisions. Again, alpelisib is a selective alpha inhibitor. And we know how important PIK3CA has in resistant to endocrine-based therapy. There's a lot of controversy about PIK3CA as a prognostic biomarker. Some people think that it portends a poor prognosis. In some studies, pretty large, more than 1,000 patient studies, actually it was a lineage-specific marker for ER dependence, and particularly in early stages, it was a good prognostic sign. That's why with my patients, I don't really talk about prognostic role of PIK3CA, because predictive role of it is undeniable. We don't have to go into controversy. PIK3CA mutation means that these tumors are more likely to respond to alpelisib, period. And if I have a PIK3CA mutant patient, this is what I tell to my patients, and I try to give them alpelisib, okay? Now, as far as the side effects are concerned, this is one very important piece of information. You can see that alpelisib equally hits mutant PIK3CA and wild type, okay? So wild type is really important for insulin signaling. Since you're hitting mutant one in the tumor and you're hitting wild type, that's important for insulin signaling. That's why you're getting hyperglycemia, because the IC50s are almost identical. Not almost, they are identical. So that's why this is an on-target side effect that's really hard to separate from the activity in the tumor, and I always expect to see some level of hyperglycemia with these agents. Luckily, alpelisib does not hit other targets well. So you have 50 times higher IC50 for delta. Okay, why is delta important? And why is it important to read papers as you develop drugs? There was a study in 2002. Okay, if you just look at that study, you could have predicted that tacelisib, that went in parallel with alpelisib, the Sandpiper data versus SolarOne data, that drug hits delta. And what does delta inhibition cause? It causes, in these beautiful mouse models, chronic colitis. And sure enough, this is what we've seen in the tacelisib study. This is what we do not see, or quite rare, that you see it with alpelisib, because it hits just alpha. Okay, so this is why it's important to look at these other targets as we study these drugs, because these details do matter. Okay, blocking alpha in terms of effect on insulin is nicely illustrated here, and I want to just quickly go over this. So insulin, by binding to its insulin receptor, activates PI3K, particularly alpha, which ultimately results in glucose transporter getting into the membrane, so the glucose can get into the cell. Okay, when you use alpelisib, this cascade gets blocked, and now glucose transporter cannot get into the membrane, and glucose accumulates outside of the cell. Okay, what happens as well is the body tries to compensate by making more insulin, so you have hyperinsulinemia. So you don't have just hyperglycemia, you have more insulin than you have in a basal state. So the problem is not about lack of insulin in the majority of these patients. The problem is that there is insulin resistance. So instead of giving these patients insulin, you're actually trying to sensitize the cells again to insulin by giving metformin. So this is a very important sort of piece of information. As in my practice, I generally almost never use insulin unless the patients already had pre-existing sort of diabetes issues, and then slowly over time they're developing not just drug-induced hyperglycemia, they're actually developing diabetes, which is rare with this drug. Vast majority of patients, you stop the drug, and the glucose quickly goes down, and they don't have any persistent issues. But there are always subset of patients that actually are essentially undiagnosed diabetes, where you may have issues even when you stop the drug. But majority of patients, it's metformin that's my standard go-to drug. And that's different compared to endocrinologists. Endocrinologists love insulin. They have numerous formulations of it. And their first drug they go to tends to be, okay, why don't we start insulin? But as you can see, it's not the problem necessarily with insulin. The problem is that there is block in signaling downstream from the receptor. And the drug that actually overcomes that is metformin. Metformin does exactly opposite to what alpelisib does with insulin signaling. Metformin enhances transcription and translocation of the glucose transporter. Now it makes sense why is this the top choice when we observe hyperglycemia with these patients. The prescribing information for alpelisib provides very clear recommendations for management of grade 1, grade 2, grade 3, and grade 4 hyperglycemia. I would like to point to you this launch meeting that it's really important to be sensitized to grade 1 hyperglycemia. As an oncologist, we could care less for grade 1 hyperglycemia. We give milligrams of decadron with taxanes, glucose goes up and goes down, no one cares. But with this drug, grade 1 hyperglycemia day 15 often will creep up over time. And if you do not act on it, you will not have time to titrate metformin, and then you'll end up in a grade 3 range, which then you have to hold the drug. So it's important to read this, consider metformin as strongly consider metformin, at least in my practice, if I see any evidence of hyperglycemia. But obviously, we all have to make these decisions and personalize them based on the patient, because some patients have GI issues with metformin, and you kind of have to carefully balance this. Okay, I want to emphasize that dietary recommendations are not sort of minor intervention. It's critically important to use these lifestyle changes to help metformin. And even if metformin and the lifestyle changes do not help, you can still dose reduce the drug. It's a travesty when this drug ends up being discontinued without dose reductions. So I think you need to carefully watch these patients in the first month and use everything at your disposals, but that includes also lifestyle changes. I had a patient who had a terrible time with the drug, with glucose, but what actually was driving everything is that she had insomnia, could not sleep, and maybe had some bone pain as well, and ended up eating a lot throughout the night, which, as you know, is pretty devastating combination, because then that morning hyperglycemia can be really, really high. And with simple change in her diet, we actually did a much better job than with any other intervention. Now, what do we need to do as preparation for giving alpelisib in terms of this particular side effect, the hyperglycemia? Well, we have to check fasting plasma glucose, and we have to check A1C, okay? The prescribing information provides very clear guidelines. What do you do then during the treatment? And what do you do if the patient experiences hyperglycemia? You have to intensify this monitoring. And often in these patients, you may need to even give the glucometer. Although in majority of patients, monitoring fasting plasma glucose in the morning before they take the drug and before they eat anything, if you can schedule the clinic in such a way, is all you need. God forbid if these patients start checking their glucose at home after they take the drug or after they eat. Then the drug is at Cmax, they ate, and now the glucose can be through the roof, but it doesn't mean anything because it's just for a few hours. It is that fasting trough, pre-drug level that really matters, but this is just something to pay attention to. Now, this again repeats my earlier remark that median time to first occurrence of glucose problems is 15 days, okay? And this again repeats how these patients have, 96% of them have returned to baseline relatively quickly. So that day 15 loading dose of fulvestrant, that's an opportunity not just to give that loading dose, but actually to check on the patient and make sure that they're doing fine. Okay, now going back to rash. This table provides a very important observation. A subset of patients, SOLAR-1, did get a prophylactic antihistamine based on some earlier results from the earlier trials, but subset of them did not. And you see dramatic difference when prophylactic antihistamine is used. 73% of patients had no rash. Only 15% of patients compared to 41 had grade 1 or grade 2 rash. And incidence of grade 3 rash also dropped significantly by half, basically. So it is really important. Patients easily forget this. I give them that recommendation to take cetirizine. I make them from day one take the cetirizine. And usually in my practice, they take it until the first scan. And then only if they don't have absolutely any skin problems, I'm considering stopping it. But I keep it until I see that first scan and make sure the patient is doing well. Now, the last part of this presentation is about testing for PIK3CA mutations. I think it's important to go back to the observation that PIK3CA mutation, PIK3CA is not just the target of the drug. The mutation of that target is also predictive for the benefit of the drug. Without testing, there is no giving the drug. So how do we test? Okay, and why do we test? Well, it's a very common mutation. No matter what study you look, it's present well over 40% or more in some studies of patients. This particular claim about worse prognosis indeed has been observed in some studies, but I want to warn you, if you really go deep and you look carefully, there are a lot of studies that somewhat controversial there, where this prognosis claim is harder to understand because timing of and the patient population that was analyzed has a huge role. So that's why I don't necessarily talk about prognostic information that comes with PIK3CA. I definitely talk about predictive, but I already said this. So this is a couple of studies that showed that it's 40% or more. The TCGA analysis, the Bolero sample analysis. And what is interesting is here, when you look at PIK3CA in metastatic versus primary, okay, you see it's very similar. That tells you, it provides some data on stability of this mutation. It doesn't necessarily matter if you test for a PIK3CA in primary tumor and metastatic, it's there or it's not there. ESR1, on the other hand, is completely different. You see how ESR1 is not that common in primary tumors. It really gets enriched. So this is completely opposite. ESR mutations tend to be, majority of them acquired. PIK3CA is that truncal event that happens very early in oncogenesis of this disease. What does the mutation do? Okay, so mutation disrupts the interaction of the brake called P85 that breaks and shuts down the function of alpha protein. Now, with the mutation, the connection cannot happen. It's like the brakes on the car cannot grab on the disc, and there's no braking. Okay, so this is what at least some of these mutations do. They disrupt this natural regulation of alpha. But what's really, really important, okay, the basal activity, it's not dramatically altered with many of these mutations. In other words, it's not enough just to have mutation, okay? You need to have other things that push on that pathway. It's like a loose gas pedal, okay? Something still needs to push the protein. That's why you can have mutation in early stage disease. The tumor is ER responsive. No one cares. These patients have actually good prognosis. But then you go to second line metastatic, the other pathways are altered, and they're really now pushing on that gas pedal. Now all of the entire pathway has increased this phosphotyrosine activation because other changes have happened in these tumors. Okay, so this slide shows some remarks about also not just why to test, but when to test. According to NCCN guidelines, it's recommended to test at the time of diagnosis of recurrent disease, but then how to test is a little bit tricky, so we'll discuss that. If you use tumor tissue, okay, the tumor is positive, it's positive, you give the drug. It's negative, you give the drug. So tissue, no controversy. However, if you use blood, if you're positive, if the patient's positive by blood test, okay, it's positive, you give the treatment. But if it's negative, it's not enough. The blood liquid biopsy tests, some of them, are not sensitive enough. And if you have a negative result, you still, to be sure that the patient is really negative, you have to perform tissue biopsy. That's why I do PIK3CA mutation analysis based on tissue from then metastatic biopsies, or even primary tumor if you have it easily available. And I get that at the time of diagnosis of recurrent disease. And then if I do liquid biopsy, I tend to do them later to look for acquired mutations. The liquid biopsies are sometimes used in some patients that have bone-only disease, maybe difficult to biopsy. They're very easy to do. You just get one tube of blood, you get results within 5 days. And then if the patient is positive, everyone is happy. However, the patient is negative, some additional work to do. And why there is a difference between tissue and blood, okay? PCR-based assay, and this is not digital droplet PCR. This is standard real-time PCR, and there is an assay called TerraScreen, and this is the assay that will come with Alpelisib that the virus will provide to you. That assay has sensitivity, the limit of detection, that goes down to about 2%. And it doesn't matter whether the DNA is coming from the tumor or if it's coming from blood. It's still about 2%, okay? Now, in the tissue, you have at least 20, 30% of tumor. If you have a mutant tumor, that means that out of these 30%, usually mutation is just in one allele. That means you have 15% mutant allele. And now if your limit detection is 2, you're well above 2, so you can detect it. So tissue, good. Now you move to blood. With blood, the tumor may not shed, it may not release enough circulating tumor DNA. It may release only 1% of tumor DNA. 99% is from white blood cells. In that case, you have 1%. Only half is mutant, 0.5%. And your limit detection is 2. Now this tumor is called negative, despite the fact that it's positive. So now you go to the biopsy, where you're at 30%, go down to 15, your limit detection is 2. Now it's positive. These tumors are either positive or negative. The problem that in blood, you do not have enough circulating tumor DNA. I have about 10, 20% of patients who have absolutely no circulating tumor DNA. They have metastatic disease, no circulating tumor DNA. And that sort of depends on analytical characteristics of the test. Some sensitive assays, such as Guardant360 or even Foundation 1, the NGS-based assays, can have a limit of detection down to about 0.5% or even 0.1%. In that case, if you have a patient with 1% circulating tumor DNA, PIK3CA is 0.5, but your limit detection is 0.1, you can detect it. Okay, so if you're using that kind of test, then it does not matter whether it's tissue or blood. But with TerraScreen, negative assay has to be confirmed by tissue. Okay, I want to point out that the SOLAR one was based almost exclusively. Majority of these patients was tissue tested, and then primary tumor, not even metastatic. And that's okay. This is one of the rare instances where it's okay to test primary tumor as long as it's not very old material. Okay, but now when we look at blood positive patients, there the hazard ratio was even better, 0.55. But look what happened. In blood positive patients, the fulvestrant arm performed very poorly, regardless of the line of therapy. It was 3.7 months. And that makes sense. Tumors that are really aggressive, they actually shed more material into the blood, and they end up being sort of, it's not just they're positive, they're more aggressive, and those tumors are not going to respond very well to fulvestrant. Okay? Now, unfortunately, with TerraScreen, you're getting just PIK3CA mutation, okay? It's very nice to get additional information with ESR1 as well, particularly for investigational purposes. And a whole slew of new drugs are being developed. We're looking at more than just PIK3CA will be critically important. Here is a very interesting analysis where mutations in ESR1 are really scary, okay? Here, with the Bolero-2 results, where you have everolimus given with exemestane, if you have a mutation in ESR1, it makes everolimus ineffective. Look here what happens. If you have a mutant patient population, even everolimus combo doesn't do anything. It's right over the placebo arm. So this is an unusual paradigm where a mutation that makes one of the drugs ineffective makes the entire combination ineffective. And that's why we have to be careful when we give these doublets or triplets even, to pay attention to mutations that completely eliminate the activity of one of the drugs, then the other drug cannot work either. This is the last slide that showed how it's important as an oncologist to learn to use both tissue and liquid biopsy. In some instances, it doesn't matter. PIK3CA can be detected in blood and tissue. ESR1 is much better to detect in blood because ESR1 can come from multiple lesions. If you biopsy wrong lesion, you do not detect it. But then ER loss or some of the other proteins, you can detect only in tissue. So we'll have to, unfortunately, it's going to be very expensive, and the cost of these workups can be significant unless these assays become cheaper and cheaper to help us actually work up these patients much better. So I hope, this is my last slide, but I hope with this I sort of covered main issues that are important to practicing oncologists as you think about patients with PIK3CA mutations, and I'm happy to now turn over back to the chair for the rest of this meeting. Thank you.
Thank you, Dr. Bijan Jurek, for excellent lecture on this pre-mutated breast cancer treatment. We have learned that mutation studies have to be done when there is recurrence after endocrine therapy. But upfront mutation studies can also use the money. Alpelisib is the choice, and it has to be combined with progesterone. The most important side effect seems to be hyperglycemia. I mean, have to be ready to face the treatment. And insulin, not the first drug, metformin is the drug of choice. And RAS is another important side effect, so it can be managed upfront with cetirizine. Other side effects are limited. So it's a very useful talk. We get another potential-free survival for 11 months in this type of mutated patients. Excellent lecture, Dr. Next. So we go to the third talk part of the webinar. There's a short baby presentation by Nova on the launch of Alpelisib.
Thank you, Dr. Subramaniam, for giving us an opportunity to present the launch AV. Rika, can we have the AV on the screen, please? Thank you, Rika.
Best of luck with Novartis. We
Yes.
go to the third part and discussion. Moderator is going to be Dr. P. Raja. He is Senior Medical Oncologist at Apollo Hospital. He is also the Director of Department of Medical Oncology at the Specialty Hospital, Chennai. The panelists are going to be, of course, Dr. Dejan Davis, kindly agreed to be the panelist. And other panelists include Dr. Viswajit Basi, is Associate Professor and Head of the Department of Medical Oncology Department, Jipmer, Pondicherry. Dr. Joseph Dominic, the Consultant Medical Oncologist, Ramachi Medical Hospital, Chennai. Dr. Suresh, Consultant Medical Oncologist, PIK3CA Hospital, Chennai. Dr. Jayachandran PK, Professor, Cancer Institute, Chennai. Dr. Jogita Martin, Associate Professor, Sri Ramachandra Medical College Hospital, Chennai. Dr. B. Prasad, Consultant Medical Oncologist, Mayo Hospital, Chennai. Dr. Suman Kalyan, Consultant Medical Oncologist, Mayo Hospital, Chennai. There's going to be another 40 minutes. Dr. Raja is going to take over. Over to Raja.
Thank you, Professor Subramanian, sir, and thank you, Novartis, for inviting me to be here. And please allow me to share my screen. And I hope my slides are visible.
Sir, they are visible.
Thank you. Yes. And now I also want to thank Professor Zurich for this brilliant lecture, wherein he took us through the journey right from from the laboratory data, from very early days of developing these drugs, to right to what has been achieved with the current clinical trials. It was a very, very insightful lecture. Thank you, Professor. And I would also thank my panelists for joining here. So moving on to this panel discussion. So starting on a very general note with my panelists, I've just illustrated the pathways wherein that depicts what happens in ER-driven tumors, and it also shows that there are several ways these they can develop resistance, and there are several drugs that are being developed to overcome these resistance. That is the overwhelming theme when you start treating ER-driven diseases. So my question to my panelists to begin with is that, in practical note, how many percentage of their patients do they finally end up seeing resistance in endocrine-driven diseases? That's my question. I'll begin with Professor Viswajit. What is your experience with when you treat endocrine-sensitive diseases? Professor Viswajit?
When we have metastatic patients and we treat them with endocrine therapy, almost everyone at some point of time will finally develop an endocrine resistance and then will receive chemotherapy. That can be anywhere between 1 line to 3 lines of therapy. So ultimately, everyone will develop at some point or the other endocrine resistance. So we don't check them for those particular mutations in practice.
That's fine. So, Dr. Prasad, how would you really figure out in your mind when you begin whether this patient is already endocrine resistant or is still endocrine sensitive? Do you simply follow the adjuvant therapy exposure and the interval, and or when you start them on first line in metastatic setting, and how soon they progress? Is that the way you are all clinical, or is there any other ways to note whether the patient has developed endocrine resistance or not?
As of now, we look at the time duration of when the patient develops a progressive disease. We usually have them evaluated once in about 3 months during the adjuvant as well as during the treatment of metastatic breast cancer. And based on their symptoms, we look at their disease progression status.
Thank you. I'll ask Professor Zurich this question. Professor, you really spoke this alpha isoforms and the selectivity of the Alpelisib today. So my question to you, Professor, is that this alpha isoform and selectivity, how important is it pertaining to the cancer of the breast? Is it very specific to cancer of the breast? And with regard to the other cancers, there are different form of kinases that get amplified. Can you please tell us about this alpha isoform and relation to breast cancer?
Yes, so I think it's a very interesting observation, and that was done years ago now, that it is the ER-positive breast cancer that has this high prevalence of PIK3CA mutations. Other tumors can have these mutations as well, particularly, for example, clear cell ovarian carcinoma, as well as some squamous tumors. However, the difference between ER-positive breast cancer and those other cancers is that we have figured out in breast cancer the connection between PIK3CA and estrogen receptor. And we realized that we're blocking both, we can actually overcome these adaptive resistance mechanisms. With ovarian cancer, with head and neck cancer, it's a little bit harder. There's huge interest to develop these drugs there, but we haven't figured out the best partner just yet. There's some work on PI3K plus ARP, there's some work on PI3K plus FGFR, PI3K plus cetuximab, but there are some challenges when you combine these drugs in combination. In other tumors, there are also amplifications. They're not as common in breast, but they're pretty, they are seen in head and neck cancers. Although initially there was a lot more of those than what we actually, when we designed FISH probes and we test the real patients, the percentage of those that was initially reported to be up to 30% is much less than what we see in the clinic. So amplifications generally I see in head and neck tumors. Mutations you see primarily in breast, although you can see it in clear cell ovarian cancer as well.
Thank you, Professor. I also would want to ask you about, most of these mutations are probably pertaining to the P110 domain and the P85. And again, with reference to the exon 20 and exon 9 part of that, does that have a bearing on whether they are whether they're going to respond, not respond? Different diseases have different distribution of these mutations.
Yeah, you're asking a very interesting question. For example, head and neck tumors primarily have alterations in exon 9. In breast cancer, it's more of kinase domain, exon 20. In the trial, though, when we studied these two subgroups in the trial in the SOLAR-1, both exon 9 and exon 20 did equally well. Now, there's about 20% of non-hotspot mutations. This is important for clinicians. If you order a Foundation 1-like assay, NGS-based assay, if some patient wants to pay for it, sometimes you can uncover non-hotspot mutations. And some of them are also responsive to alpelisib. You just have to be careful because it's not one of those core mutations that were studied in a trial. But I think hopefully with some additional analysis of the samples from the trial, we'll actually understand these non-hotspot mutations outside of the core mutations that were used in the trial.
So, shall I comment a little bit? So I went through an literature, phase 2 literature, looking at the type of mutations. It was mentioned that the exon 20 mutation involving X107R was more sensitive than the exon 9 mutations. Some of the publications on that. Can you enlighten on this?
Yeah, this is what was surprised. If you asked me before the trial, I would tell you that H1047R mutation, that's the mutation that my patient in that story has, the kinase mutation. I would tell you that those patients would do better. But a little bit surprisingly, and maybe that has something to do with the fact that you're giving two drugs, not just one drug. Maybe with one drug, you see the difference. But when you give two drugs, they seem to do equally well. We could not see this difference. And again, you remember a lot of preclinical work is done with just one drug, just with alpelisib. But when you give it fulvestrant, it looks like it's a wash. So I generally, if I see either exon 9 or exon 20, I'm happy. I mean, I can give them alpelisib.
Going on to the case, we have a lady who is 63 years and postmenopausal and was diagnosed as breast cancer, and 5 years post the adjuvant therapy develops metastatic disease and receives first line therapy with CDK4/6 inhibitors with the AI combination, and has a PFS of about 10 months, and around 10 months of the CDK4/6 therapy develops back pain and is found to have a metastasis, and then when mutation status was aside from the archival tissue, was found to have a PIK3CA mutation, and the patient tests positive for that's the case. And in summary, the arrow of timeline is that adjuvant therapy and 5 years doing well, and then about 10 months of PFS with CDK4/6 inhibitor. That's so. I'll turn to my panelists. I'll turn to Dr. Jayachandran himself. He's a professor in one of the teaching institutions. So Jayachandran, do you think that all patients of advanced breast cancer we should consider mutational analysis? What is your answer? Yes, no, limited? If you can be brief on that.
So, looking into if the availability of Alpelisib, I think we should test all the patients with the metastatic breast cancer. We have a lot of experience on CDK4/6 inhibitors. After the use of it, I think it was absolutely necessary to test such patients who are affordable. So, go ahead with Alpelisib. One such patient I have tested, and I have used it for one patient also.
Yeah,
I think it is essential to test when we have it available here in India.
I'll go to Professor Dominic here. On a practical note, how many patients today in your clinic, not after Professor Zurich's lecture, before that, how many patients are you routinely testing for mutations, Dr. Dominic?
Hardly any, because we didn't have any drugs beyond CDK4, and the next option would be everolimus exemestane, which was for everybody. So hardly any till Alpelisib will be available.
Yeah, that's the kind of reality as of today. That's perfectly fine what you have said, but that clearly a benefit in doing these mutation analysis, and we see that nearly 50% plus patients are going to put those potentially actionable molecular alterations in metastatic breast cancer. So this landscape is very familiar to all of you, but I've just talked about what is practical and what is aspirational. And then coming to the question, I will go to Professor Suman Kalyan. There are many alterations that you can pick up if you venture to do these tests. My question is that how many of them are actionable? And if you look at the ESMO actionability of these targets guideline, how many of them do you think in real time today are actionable according to you, Dr. Suman?
Most of them, practically speaking, they're more of prognostic value to discuss with the patient rather than on a therapeutic basis. That is just my take. So only recently, honestly, I've been doing PIK3 itself from April. My first patient was by April. So yeah, other than prognostic value, I don't find much of a value in
yeah, we heard about the prognostic and predictive way of looking at it from Professor Zurich, and it's perfectly okay at this point in time, since the accessibility of the drug is still questioned. So actionability is probably related to the accessibility to the question, so that's fine. But coming on to the patient, who is at present, has metastatic disease, then I will turn to Dr. Jovita. Jovita, would you want to, in general, when you see metastatic patients, ARPR or whatever, do you routinely do rebiopsy in your practice today? What is your, preference to do rebiopsy or not, Dr. Jovita?
Yeah. Good evening, sir. Hope I'm audible. First of all, I would like to thank you for including me in your panelists list. And I thank Professor Jurek for an excellent exposition. And coming to the answer of this question, yes, I would definitely want to have a rebiopsy, especially if there is visceral mets. The only take is that if it's a bony mets, then maybe it is not really going to yield us certain informations that we would like to. And the other thing is, also with regards to the PIK3 and the other mutations, I think the requirement of the knowledge of whether or not the ESR1 is present, as Professor Jurik said, is extremely important. Because the other thing is, there is a
Jovita, you have muted yourself accidentally. I can see that. Doesn't matter. I'll go to Dr. Suresh. Suresh, do you also agree that you should biopsy all patients, at least on metastatic disease or on progression? What do you do, Dr. Suresh?
Yeah, any patients on progression, we do it, sir. We do it to see whether there's any discordance in the ER, PR, and corrective status. Yeah. And beyond first, if it is going to be first line, we do only these 3 mutations. We don't look for PI3CA mutations. Only after 3 or 4 lines we do for PI3CA, and that too only recently. But any patients who are coming up, and this case, the ER positive only with bone mets, yes, we think it's typical for an ER failure. Whereas if it's any other visceral thing, we'll be doing a bony, any biopsy.
Yeah, that's very important. You talked about the bone sample and the difficulty in achieving these mutational analysis. That question.
So I would like to, sir, for the purpose of PI3CA mutation, I think rebiopsy will not be essential. Only for the purpose of, as all people said.
This is really about the practice of.
Yeah, in our practice, really we do rebiopsies for all patients who have an accessible site. And it is for looking at the loss of ER receptors or HER2 receptors. And again, PIK3 mutations in this area is going to be present even in the upfront biopsy also.
That's true. This is more about, what's the practice
loss of
biopsy and then what is the concordance. Very, very general.
Okay.
Yeah. So then, so I'll also then ask Dr. Biswajit, what is the percentage? Can you put a number on how many patients do you really rebiopsy today?
My practice, it's only less than 25%.
Less than 25%. So if I can ask Dr. Prasad also, what is the percentage you would rebiopsy, Dr. Prasad? Dr. Suman, if you can hear me.
Yeah, I can hear you. 50%.
So that's the general practice. So now, Professor Jayachandran just now told that, he wouldn't worry. He would just go back to the archival tissue. But then we heard the lecture from Professor Zurik. So from that point of view, I would ask, I will ask Dr. Suresh, what do you think today if there is a patient and if you are beginning to think about PIK3CA mutation and an intervention accordingly, what will be your ideal specimen that you want to send for analysis, Dr. Suresh?
So ideally, it will be a tissue biopsy. And if you have an archival tissue, it's fine. Or if there's no archival tissue, I would like to have it from a new lesion. And as Professor has already mentioned, we have a bony lesion, biopsy and demineralization of the bone, it will be very difficult. We can take up the plasma serum. So ideally, tissue biopsy will be more than good.
Fine. So we'll ask Professor Zurik. Professor Zurik, we heard from all the panelists that their appetite for rebiopsy as of today is around anywhere from 25 to 50% on a practical note today. And there are general international guidelines about biopsying, encouraging biopsy at first metastasis, so on and so forth. But there are no expert guideline or consensus as to the timing of PIK3CA mutation testing to be done for the patient at the beginning or at when we encounter progression, whatever be the tissue that we use. So, is there a guideline, or you can guide us, Professor Zurik?
I think the best we have is NCCN panel did suggest testing on the time of diagnosis of metastatic disease. Now, in terms of what tissue to use, interestingly, Mass General, the rebiopsy rate at the time of metastatic disease is relatively high. in my practice, it's very rare that I do not biopsy patient metastatic disease. It's sort of a life and death decision. And we are lucky to have a very good interventional radiology. And generally, the rate of biopsy in my practice is very high. It's probably 90, 95%. But that's unique to our institution. Even outside of our institution, those rates, even in US, are much lower. There are obviously a lot of sort of, it's an invasive procedure and so forth. It costs money, and scheduling issues. Sometimes just clinical decision matters. So that's why I tend to perform PIK3CA mutation analysis on that metastatic tumor. And then in some patients where that's not possible, if I have a primary tumor that's no more than 10 years old, I'm equally comfortable testing primary tumor. And again, in SOLAR-1, majority of these tumors were archival primary tumors.
So can you tell us, on a percentage basis, how many of them would you have on a fresh tissue or on blood, particularly when you want to look at this PIK3CA? Granted that in Mass General, you are doing it when you have a very, very standard approach of doing it upfront. Then what is your percentage of what is this that you did? Archival tissue, fresh tissue, blood? Can you give us an idea?
As I said, vast majority of patients are reflex tests that it's done together with receptors it's like a fourth biomarker on that metastatic biopsy. Now, I can tell you, since we have multiple satellites to our institution,
okay.
We have more than 10 hospitals that are our satellites, like community centers where oncologists have different practice patterns. It's very rare for them to send tissue because you need extra staff to get the tissue cut and send out. They love doing blood.
Okay.
They love doing Garden 360, which just in the clinic at the first visit, you send the blood and you get the result within 5 days. So whatever reason this is, and we're now trying to figure out for our entire network how exactly to use all these tests. But at the main hospital, we do it on tissue together with receptors from that biopsy. But then in community, they love the ease of just tumor, just a blood sample, and they send it to Guardant, which has sensitivity down to 0.1%, and they get mutation status off of Guardant 360. So I hope, it's almost, I would say, yeah.
I can ask you one more, add-on question to that. In your presentation, you showed that you have a reflex testing, and I think it's a snapshot reflex testing. What exactly does that include? Since you're doing all that upfront, what does that panel include? Can you give us a sense of what is that you are doing routinely?
Oh yeah, so we've been very involved with that EGFR mutation discovery with EGFR inhibitors since 15 years. We have this mutation profiling assay that our molecular pathologist developed. It includes some of these major oncogenes. Foundation medicine assay is also very commonly used in the community and has almost more than 300 markers, but not all of them are actionable. In breast cancer, all you need right now is ER, PR, HER2, and PIK3CA. So I think there's some trade-off between large panel and smaller panel. I think the first mutation out of the all that we have, ESR1 obviously is the first one that's going to start gaining some traction. Since we do not use TerraScreen, we do not use PCR-based ctDNA assay, we don't have issue with reflex. So this is, if you use TerraScreen, you'll have a false negative rate. If we use ctDNA, we use Guardant. It's a lot more sensitive. It's 0.1, but it's more expensive and so forth. It's not as easy globally to administer. And then we don't have this issue. If you get negative ctDNA, you have to do tissue. I usually with that assay, you can always detect a little bit of ctDNA.
Yeah, I'll turn to my panelists. Dr. Dominic, today, if you have to do, or Monday, if you have to do, if you are looking at this, establishing this mutational status, what is that test that you are going to recommend, Dr. Dominic, given these options, TerraScreen PCR kit or an NGS platform? What is that you want to do? What is your idea today after listening to Professor Zurik's lecture?
I would do the TerraScreen, the PCR test on tissue, because most patients have biopsies which are less than 10 years old, and surely many of them would have been biopsied at the time of metastatic disease. So the TerraScreen PCR, most patients would go on to that.
And can you also tell us where is the availability of this test?
Hello. I think currently Novartis has a support which helps. I've recently done it for just one patient of mine, and I think Novartis has a support for that. So probably somebody from the Novartis team would be able to throw a little more light on that.
I think FDA approved TerraScreen test is not available in India. So I think so. Probably the local NGS with the Sanger sequencing was available. One of my patients I did actually. So it was available with Core Diagnostics, which is what was recommended by Novartis people for my patient. So I did it. It was a local PCR with the Sanger sequencing, looking at exon 9 and exon 20 hotspots.
Perfect. So we'll ask Professor Zurik. This is the kind of retrospective comparison between the PCR done and the NGS later on. And if you look at the patients who were demonstrated to have the mutation or was negative, then went on to be assessed by the NGS, there is still a bit of discordance, around 92% concordance in the positive patients and around 80% concordance in the negative patients. So that leaves about 10% discordance on both the arms of this analysis. It's retrospective, but then what does it tell us? That PCR is not the best way finally to go? Can you educate us, Professor?
Well, it's tricky. We're now actually, we're going to present at San Antonio some of these data that we updated. It's tricky to understand fully these discordant cases. I would say in some instances you have technical differences. I think NGS assay is a little bit more sensitive to the quality of tissue. And I usually, PCR-based assays are, I did it in the lab when I was a postdoc. They're very, very simple. And they can, on the tissue, they can detect, they have very good characteristics. But then depending on the quality material, NGS library can sometimes fail. On the other hand, if you have there are rare patients where you have subclonal PIK3CA mutation. That's an exception to the rule. Majority of patients are clonal. I suspect there may be some where different cut of the sample or different type of sample, you can have some differences. So we'll have to learn. We'll have to learn from these additional analysis what it really means. This small subset of patient where you have a difference between PCR. I generally like PCR when it's done on the tissue. When it's done on the blood, unless it's a digital drop of PCR, it's not very good. But on the tissue, PCR is really good. And it's a lot less prone to errors in tissue handling and preparation.
Assuming that line of thought, when what you said, I just want to quickly show. We have been routinely doing this, and we have several patients who have demonstrated positive. I'll just show you a couple of patients whom we have shown the positivity. This is an iron torrent NGS hotspot panel of 52 gene hotspot panel, and this is the report. This is the kind of report that I get. And this is a lady who is 55, has a positive PIK3CA at, as you pointed out, H1047L domain. This is another lady has H1047R domain, if I may call it. And then, my report also elaborates that the percentage and their pathogenicity and the clinical significance. My question to you is that, how do we establish the clinical significance whenever we see these variants, and how do we establish the pathogenic significance of these reports? Now that we all want to do this, and we are now routinely doing this, can you tell us? You have to go to these.
Yeah, I'm glad you showed this. It's very nice to see because different countries have different reports. It's kind of nice to see them. I'm glad that your reports give you the perspective.
FGFR one amplification, we simply did not know how to put this into perspective. I heard you say about multiple things getting amplified, and how do I pick which is the best driver here, and so on and so forth. And
yeah, I think in terms of unfortunately, the way things are currently, we use each biomarker on its own. So we look at PIK3CA and make a decision based on that. We look at FGFR, we make decisions based on that. So there's some hierarchy in how we do this. But I hope that with artificial intelligence, with proper algorithms, they can read input of multiple biomarkers. Our brain cannot process this as easily. If you have multiple positive findings, this is going to be very challenging to assess an impact of one, the other, and then the other one can cancel it. It's going to be very, very hard for us to just use a simple approach. Right now, this is all we can do. We see PIK3CA, we give Alpelisib. We see FGFR, we give experimental FGFR inhibitor. If we have a trial where Alpelisib is given together with FGFR, then it's beautiful. But we have not that many combinations like that. So I'm sorry for disappointing you. It's not very simple when you have multiple.
It tells me to, they go to the database, and then that's what they send me. And I am at a loss, but I see, as you rightly said, if I see a test, if it's positive, I'm looking for the drug. That's all my short algorithm is. And
but you're bringing very, very important thing. That's why in my institution we are now currently setting up something, an e-consultation service, where every report will be not just issued, it will also be reviewed by a trained molecular pathologist, and then things prioritized, and you'll be able to discuss it. It's very expensive and involved, but there is a recognition. And by all oncologists, these reports are getting more and more complicated, and you cannot spend 2 hours digging through literature yourself, or you cannot use just a list. So you need something in between that it's more of a consultation where it tells you, look, based on the impact of these, this would be the rank list, but that requires more time, and it's a bit of like a consultation. It cannot be easily automated at the moment. So it's a challenge. And then we have these molecular tumor boards where really complicated cases have like 15 different alterations are discussed.
Professor,
so
we are really happy that you say that it is complicated to understand.
Oh, it is. Oh, it is. Yeah.
I'll turn to my panelists. Dr. Jovita, you heard Professor Zurich about the PIK3CA mutations being prognostic and predictive. What is our take home? Do you think these patients are worse prognosis? And what is your take home from what he said, Professor Jovita?
Absolutely, sir. The prevalence of PIK3 being 40%, the coexistence of ESR1 makes it a little difficult in terms of using the PIK3 inhibitors. It's going to be resistant. And also there will be increased brain metastasis. So that's what I was about to tell previously when my line got disconnected, I guess. So I think that prognostically, it's extremely important to have the knowledge of these, of PIK3. And an added comment, actually, as Dr. Jurek had spoken about the PCR, I just wanted to know if, the droplet digital PCR and the beaming digital PCR is being used.
Professor, she wants to ask about
the droplet digital PCR and the beaming digital PCR, because I guess the sensitivity is quite high, even as less as 0.01% of the alleles. I think the pickup rate is quite good. So Dr. Jurek, what is your take on that?
Yeah, I think in our research enterprise, we have developed more than 400 digital droplet PCR assays, including for PIK3CA. This is considered a gold standard in terms of analytical characteristics. It's not necessarily used in the practice at the moment. But yes, those assays have really interesting analytical characteristics that are very sensitive.
Thank you,
Thank
Prof.
you.
I will now speak to the patient, and now we have detected, let's say, this PIK3CA mutation. And Dr. Suresh, tomorrow when you go back to the clinic, would you consider a confirmed positive patient who has progressed on CDK4/6 inhibitor and aromatase inhibitor? What is your thought process today? Would you consider this drug? What is your choice? I have given some options to you, Dr. Suresh.
Yes, sir. Ideally, I would like to start the patient on Alpelisib with fulvestrant.
Okay, so you're convinced about what Professor Zurich presented today, and
Yes.
so I can also ask Dr. Biswajit, are you convinced? We ask this question. We will look at the line where we have to place this. There was also a panel question. One of the chat question, whether this particular drug is going to work on first line, second line, third line, and fourth line, so on and so forth. So, Dr. Biswajit, are we convinced that we should practice SOLAR-1 data tomorrow?
So, with respect to the SOLAR-1 data, the data on CDK1 inhibitor failure is not there, but we already have data in the ASCO, which Dr. Rugo presented, saying that post CDK inhibitor also there is definitely a benefit, but the benefit may not be as high as we are seeing with the SOLAR study. So it was, I think PFS was around 7.5 months in that subset of patients. So definitely a failure to CDK inhibitor, definitely, and if you have a PI3CA mutation, definitely fulvestrant with Alpelisib is definitely a no.
It was Alpelisib, and you heard his presentation, SOLAR-1 PFS and the response rates and the hazard ratios that he presented. And he showed that it works across the board, across all presentations. So,
just one question in that is that why did the bone alone group actually there was not? I mean, it's the confidence interval seems to be crossing all over. So I think some subsets of patients like the primary resistant tumors, the bone only disease, I'm not sure how much benefit will this two subset of patients get with the PIK3CA mutation.
He's the one of the primary investigator. I think he can answer this question. Bone only disease, Professor Zurich. Do you think still there is a strong case for using this?
Yes, I mean, look, whenever you do this subgroup analysis, it's a problem because you're losing the power. The hazard ratio there was 0.62. So in the entire study, it's 0.65. So we don't have a reason to believe that bone-only patients wouldn't benefit. It is true, though, that fulvestrant can perform much better in bone-only disease. And I think it's a valid question whether alpelisib really adds as much. The data suggests yes. In my own practice, and one thing that I follow with these patients is bone pain. It's really hard to look at imaging or anything pretty much. If they have bone pain, I give them alpelisib, and 2 or 3 weeks later, they say that they don't need breakthrough pain medication. To me, that's all I need, and I have seen a lot of patients that clearly benefit. So I gave you both the numbers and literally my own experience in terms of bone pain. So yes, I do give these patients alpelisib.
You also mentioned about the data set from the SOLAR-1, which was presented this ASCO, that the responses are also equally established when you test in the plasma ctDNA. So you went on to allude that. So then the most important question, we need to sensitize ourselves from what we learned from your presentation is about being very, very, very alert about hyperglycemia and then learning to manage the rash. So that seems to be the key cornerstone in trying to master this drug. That's what we understood. So I'll go to Dr. Prasad tomorrow, if at all you want to start a patient, you want to manage at the first sign of high sugar by yourself, or would you want to involve an endocrinologist, Dr. Prasad?
Basically, I think the endocrinologist should also be told about the mechanism of action of the alpelisib, of the down regulation of insulin receptors, because this is quite a completely new drug to them. So they should not just routinely use the regular algorithm for diabetes management. Probably they have to be taken on board when we treat the high sugars as well.
Yeah, Professor Zurich did allude to about the mechanism of insulin resistance and being very, very alert on how do we identify and quickly try to be on the action plane. Dr. Suman, if you have a patient, if you're thinking about a patient, what is that in your mind that you want to do about your diabetes or potential high sugar management?
So I took the screenshots of Dr. Zurich. I think that will do. So beautifully presented about management of hyperglycemia. So what struck me was metformin is more important than insulin, and it's better to have, as Dr. Prasad told, an endocrinologist on board. Let him be aware before even I start the treatment. So that's how I think I'll go about.
That's how you will go.
Let me pitch in some. So I have a small difference in opinion. As Dr. Prasad said, I had a very bad experience with one of my patients who was on Alpelisib. Unfortunately, was diabetic. Unfortunately, the patient was diabetic, but it was a fairly controlled diabetic with the HbA1c of 6, less than 6 before starting the drug. But I had to explain the endocrinologist that the exact mechanism of how when I started the drug. I started it on 200 mg only, the second level dose only, but the blood sugar started shooting. Even the fasting levels are on 500 on the day 7 of the drug. So I had to explain my endocrinologist that insulin will not work in this situation. And then I had to, already the patient was on glimepiride and metformin. So I had to put them on additional drugs with, I increased the dose of metformin. I added an SGLT2 inhibitor, empagliflozin, and then with that also, again, the patient do not tolerate. So again, every time I had to stop the drug, the patient blood sugar comes down as soon as within 3 days. So again, this was a very bad experience, and that last patient did not tolerate even the lowest dose. I even tried a substandard dose of 100 milligrams. It too didn't work. So I had to withhold the drug completely. Every time when I started the medication, the blood sugar shot up, the fasting blood sugar shot up to 500, even at the lowest dose possible.
Yeah.
It's a very challenging situation, and in case of that, always in a non-diabetic patient, that's a different ball game, and the diabetic patient, it's always a nightmare in our with my experience in.
No, you are perfectly right. It is very important to talk about the rough rides and learn from that experience. There's no question about that. The professor did talk about how being alert from early on, and there is also, there is also kind of a. If you look at the clinical trials, evolving clinical trials, they try to avoid. Clearly insulin-dependent diabetes mellitus patient or refractory type 2 diabetes, all that is already there. But there is a drug, there is a difficulty how to master that. So it's very important to learn from your experience and what he illustrated. Thank you for mentioning that. My question to Dr. Josh Dominic is that we heard about the diabetes, and how important do you think is a rash also in your management? Now that we have so many drugs that are causing skin rash, and we have kind of settled down how to manage skin rashes in our patients. Dr. Dominic?
I think the early use of antihistaminics is a blessing here because we don't see that kind of response in the other drugs that cause rash. So probably an early use of antihistaminic would be the way to go.
Yeah, so early use of antihistaminics, and as Dr. Jayachandran clearly pointed out, how difficult if you are not able to manage, and even an endocrinologist needs a bit of learning time, I believe. So if you look at the cardiologists, we now have specialist cardiologists who focus on oncocardiology. So I think this is also a kind of a learning curve. So granted, to hear your difficulty, we'll all learn from that. Coming to the holy grail of now, how to sequence all. Yeah, yes, Professor.
If I may, I think it was really nice to hear about a first-hand experience with diabetic patient, and I had those patients myself. You think that they're perfectly well controlled, but there is just inability of them to compensate for that block. And I even myself had patients who, despite trying the lowest dose, they just couldn't do it. Another patient population that's very interesting is patients with gestational diabetes. That's something that I always ask my patient, did you have problems with gestational diabetes? Because that's like a stress test. And it's similar to giving the drug. And if they had really bad time during the pregnancy, something to think about. I think for rash, I think just a little tip, advice, you start everyone on cetirizine. And if they do develop rash, you can give them topical steroids on symptomatic areas. But if the rash is anywhere more significant, a beautiful regimen that works almost universally in everyone, you give them prednisone. I give them 40 milligrams for 2 to 3 days, and then 20 milligrams for 2 to 3 days. In majority of patients, the rash goes away. Now, you're worried that with prednisone you'll have hyperglycemia, but if you do something around 40 milligrams, they're usually fine. And it's just a couple of days. And patient gets scared because the rash is like all over the skin. And then they take 2 prednisones, 40 milligrams, and within a day or 2, they start seeing improvement and they get encouraged. So it's just a little tip. Those systemic steroids do help dramatically in patients who have more significant rash.
Thank you, Professor, on giving us that tip. And so,
if I may, if I am allowed, can I ask a question to Dr. Zudik?
Jayachandran, yes.
Dr. Zudik, I have a very important ringing bells in my mind. So if you compare the data of Mona Lisa 7 and if you compare the data of SOLA 1 trial, so when you look at the comparator arm, the placebo arm, the survival seems to be totally different. I went into this day when this was keeping on. The survival on the Mona Lisa 7 was around, the placebo arm was around more than a year. That was more than less than a year, around 6 months in the SOLA 1 trial. When I went into the data and then I saw that the inclusion criteria of the patients was totally different in these trials. Was that this Mona Lisa 7 had a lot of endocrine sensitive patients, as SOLA had around 85% of the endocrine resistant patients. Could you expand on this actually? Because both first line and second line are included in the SOLA, whereas in Mona Lisa, I think it's only the first line patients, I suppose. Very few second line patients.
Yeah, exactly. I think you yourself observed a very interesting.
Can you expand anything to ask anything difference between add up to this?
That's exactly the difference that you observed. I think the fact is that PIK3CA mutation really needs to work together with other alterations to activate the pathway, and that happens in really resistant tumors. If you're sensitive to endocrine therapy, that PIK3CA is there, but the pathway is not activated, and you're not going to necessarily see a lot of benefit, and also the control arm will perform differently. So to me, it's these resistance patients, particularly in second line, that I go after with Alpelisib.
What exactly endocrine resistance or sensitive patients did in the SOLA? Did they do as good as what was in Mona Lisa 7, or was that different? That's what my question was.
I don't know. To be honest, I don't remember exact number because it was really small number of patients. The hazard ratio was close to 1. It was like 0.9. But in terms of the absolute number, I don't remember on top of my head because it was a very small number, and we excluded that patient population from the subsequent amendment to the trial. But I can easily find these numbers for you if you give me time.
Thank you.
Can I have a supplementary question on that, Dr. Zurik? Hello?
Dominic, yes.
Question is, if you're choosing between fulvestrant and a CD4K6 inhibitor versus fulvestrant versus Alpelisib, because quite a number of patients get only letrozole first line, in those who actually have a mutation, how would you go about that?
I will come to that, Dominic, in a minute. If you Professor. I just want to come to the last section of how do we handle these choices. Now we have multiple options, and we have a challenger in the form of everolimus and exemestane data, And between the two, how do I choose the PIK3CA inhibitor? That's what I wanted to ask you. Particularly looking at the Bolero data, you did elaborate on that in patients who have these mutations. The everolimus did okay, but still, in wild type it did okay, but in mutant, even that was not good. So that's what we understand. So between the two choices, and there was a data set presented as a poster by Professor Rugo in this ASCO as kind of an indirect comparison between the Bolero 2 and the Solar 1, and that's the kind of conclusion that she would draw, that there is a kind of superiority with the Solar 1 data as compared to the Bolero 2, even though this is not exactly a head-to-head comparison. So between this and the BILEAV study presented by Dr. Rugo once again, how do we sequence our choices now between the first line, second line, third line? Someone had that question on the availability of everolimus. How do I sequence today my endocrine options?
Is that for me?
It's for you, Professor Zuri.
Yeah. I mean, obviously, that's a billion-dollar question. Sequencing trials are really the hardest to do because you need massive amount of time, but they're going to be extremely important. I mean, I tell people right now when we do trials is like using GPS. It tells you how to get to the first corner. You need to go home. How do we do it? Generally, I favor CDK4 inhibitors over PI3K. Why? Because there are multiple trials with overall survival benefit. Okay, so if a patient hasn't had a CDK4 inhibitor, I'll generally give them CDK4 inhibitor unless there is some combination. There was a question if the patient had upfront AI only. Generally, we don't, in the US, that's sort of dying slowly. Majority of patients get upfront CDK, but for some reason they get AI upfront. I give them fulvestrant CDK, and then I'll use PIK3CA later. If the patient gets up from CDK with AI, I give mutant patients fulvestrant alpelisib and wild type patients fulvestrant everolimus. It is not fair. It's not fair to compare fulvestrant alpelisib to exemestane everolimus. That comparison, in my opinion, that's why I'm not on that poster. It's not fair because if you have 30% of ESR1 mutants, you shouldn't be comparing this. So the much better study to use is PRECOG study, which had about 120 patients where fulvestrant everolimus was used. And I always give everolimus now with fulvestrant. And because they had PFS about 10.3 months. The sad thing with everolimus, PIK3CA mutation do not predict response to everolimus. So there's something not right there. Why PIK3CA mutants do not respond better to everolimus than wild type? I can wave my hand, but we don't necessarily fully understand because it's part of the pathway. The response rates are nearly not as much as with alpelisib, and the PFS is numerically still less. So I favor alpelisib, of course. It's a global trial with more than many more patients than PRECOG. So to mutants, I give alpelisib, but to wild type, I give fulvestrant everolimus. There was an excellent question. What do you then? Let's say you have AI CDK, then fulvestrant alpelisib. What now? A lot of these patients, you can try fulvestrant everolimus. We recently published some data on using abemaciclib in these late-line patients, and there is activity with abemaciclib even in patients who had prior palbo or ribo.
Single agent.
Yeah, either single agent at 400 milligrams, 200 BID. You use single agent or sometimes combo. So it's a little bit trickier. Third line, we don't necessarily know. So that's why these patients go on trials.
Thank you. Since we have very little time, I'm just coming to the last question. Do you have some comments on response in brain metastasis? There is an anecdotal patient that is demonstrated here that shows response on the MRI in the brain mets. Your comments on brain mets and you have really educated us on all the considerations. How do we approach initiating this drug on brain mets? What is your comment, Professor Zurich?
No, this drug doesn't penetrate the brain barrier very well. So anecdotal responses can be seen like with any drug, TDM1, but it's not, this is not what you would expect. Some dedicated brain penetrant PI3 kinase inhibitors have been attempted. Entech has one, but it's a little bit challenging. I think that's the next frontier, to develop brain penetrant PI3 kinase inhibitors and mutant selective PI3 kinase inhibitors that block just the mutant protein. So that's the next frontier.
That was actually from Dr. Hope Rugo's clinic. But anyway, thank you for all your insights. And it was a very, very educative session that we had with you. And my panelists were also very excellent in their proactive questioning. I really enjoyed this leading them, and I learned a lot. And thank you for this opportunity, Novartis. I give it back to Novartis.
Thank you, Dr. Raja, and wonderful moderation and wonderful discussion which happened during today for the event. One thing, a couple of things which I would like to address, especially regarding the testing which came out during the discussion, was that the FDA-approved TheraScreen PCR kit is now available in India for your usage for your patients, and we have partnered with two of the large laboratories with a good network, Core Diagnostics and MedGenome, to provide you with that testing. So it's at a very subsidized cost. So the tissue sample will be tested at around 4,700 for the patient, and the liquid sample would be tested using the same kit around 7,000 rupees. So more details and the program can be explained by our local colleagues in Chennai, and they can get back to you on that. And we have already seen that some requests we've already got from some of the panelists and doctors who are part of this, who have already used this testing facility. And one more key important point which I would like to highlight is that we've also made sure that we bring the drug at the best price possible to all the Indian patients. So the maximum retail price for Alpelisib, that would be called as Pivicto in India, would be around 72,000 per month. That would be the maximum retail cost. And more details around the same can be communicated by my local team to you. That's it from Novartis, and thanks a lot all the esteemed panelists, faculties, and our speakers, and special mention of Dr. Subramanian, who gave this opportunity for us, and Dr. Jurek, who gave us time on a Sunday morning, so it really means a lot to us, and a special mention of Dr. Raja, who you really did a wonderful moderation for us, and it was really insightful and learning even for us. Thanks a lot. Over to you.
Why don't you give us a patient support program, cost reduction, so all our patients can benefit?
Yeah.
Everyone,
Yes.
that's all I can ask.
Yes, sure. We'll take your feedback, sir. Thanks a lot.
But I give it back to you.
Yes. Yes.
Good night.
Yes.
Good night.
Thanks a lot, Dr. Subramanian. Over to you. Vidyut, can we close the meeting?
Piyush?
Okay.
Yeah, Piyush?
Thank you. Thank you, team.
Thank you.
Thank you, one and all.